Good evening. My name is Dr. Willie Spires, and my title here is I'm in charge of the Social and Behavioral Sciences, Math, and Natural Sciences. First of all, I'd like to welcome all of you here to the college, and we know that it wasn't for all of your participation, this event could not be possible. This is our 7th annual Mental Health Symposium. And I think with the efforts of all of us, we work in concert, we will make our society and our world a better place to live. We want to certainly encourage people to receive services as soon as possible because we know that the sooner the service is received, the better the prognosis. And we want to erase that negative stigma that there's something inherently wrong with getting mental health treatment if you need it, or any other service providers that are here tonight. So we'd like to do that. I would be remiss also if I didn't recognize the individual who's responsible for making all the phone calls and having this layout done. That's Professor Linda Morales. I think the last time you were here, she was my assistant. She left me, and now she's Professor of Psychology. So let's give her a hand, okay? Okay. All right. I'd like to recognize all the agencies that are here, and you can choose someone as we recognize everybody who's going to be the spokesperson, because I will later ask you to come up and tell a little bit about your agency, okay? So the first individual I want to recognize is Ms. Karen Edwards with the Jackson County Health Department, and her assistant. You stand, please. Thank you. Thanks for being here. Okay, we'll call you up later on for that. Okay, all right, thank you. Okay, and then we have Behavior and Life Connection LLC, Ms. Doe Jackson. Let's give her a hand. Okay. Okay, the Anchorage Children's Home, we have Mrs. Amisha Long. American Foundation for Suicide Prevention, Ms. Brittany Barnes. Okay. One Step at a Time Incorporated, Ms. Trivia Masseline. Okay. Gulf Coast Sexual Assault Organization, and we have Ms. Marsha Crew. Okay. Florida Center for Early Childhood, Ms. Jennifer Worden. Okay, we have Bay County Vet Center, Mr. Matthew Standish. SOAR, Ms. Christina Tolbert. And we have Vocational Rehabilitation, Ms. Tiffany Sori, Darlene Borking, and Ms. Paula Wynn. Chemical Addiction Recovery Effort, we have Ms. Jen Richardson and Ms. Rose Smith and Mrs. Kelsey Davis. I'm sorry, I left your name off of that one. And then the last one, we have the Hope Project, Kevin Holland, Ms. Bunny Blackman, and Mr. David Trogodon. Okay. Did I omit anyone? Okay, maybe I was inclusive there. Okay, then we have, I don't know if Dr. Christy Ford has gotten here. Yeah, okay, there you are, okay. We have Dr. Christy Ford, who has another engagement, but she graciously agreed to come and be our guest speaker tonight. So Dr. Ford, will you come up, please?
Well, good evening. It's so great to be here tonight and nice to meet all of you and see so many representatives from so many different organizations. We've been coming here for quite a few years now. Thank you, Dr. Spires, for putting this on. It really does matter that we come together and network and just see who we are, right? Who are we and what does our community look like in terms of what it offers to be able to connect with each other and really network. I know several of you I've seen here in years past. I see a couple of new ones, so I'm looking forward to getting around to all the tables and meeting you and figuring out what all we have to offer to one another. You know, when Dr. Spires asked me to do this, he said, let's focus in on why does community mental health matter? Right? Why does it matter if we do this? Why does it matter if we come together? I don't know about you guys, but I love Marianna, Florida. I love Jackson County. I love the Panhandle. I love this area. If you call this area home, I hope that you look around with a sense of pride and you say, hey, this is my community. This is where I live. This is where I'm responsible, right, for pouring in and making sure that my gifts are offered in a way that I'm doing my part to make sure this community is all that it can be. So if you love your community, my next question would be to you, what does it take to make sure our communities are healthy? What does it take to make sure that we're working together? You know, communities are built on relationships. So we got to get to know each other, and we got to be in relationships. And relationships require something else, which is the coming together of healthy people. Communities are built on individual selves. So we have to ask one another, how healthy are we? How healthy are the people in our community? We talk a lot about community health in these kinds of forums. Sometimes we talk about, do we have good systems? What about safety? What about transportation? Do we have healthy economic development? Is our outlook good, right? How's the economy? Is it healthy? But how often do we ask one another, how are you doing? Are you healthy? What does healthy even look like? Now, I'm assuming students, right? These students are psychology majors. Some are just here to listen in with friends, and that's okay too. So if you don't know much about psychology, I'll tell you this. Psychology tends to focus in what we call the therapeutic triangle. All right, therapeutic triangle is your thoughts, your feelings, and your behaviors. So we talk about healthy and unhealthy thoughts, healthy and unhealthy feelings, healthy and unhealthy behaviors, right? So if you're unhealthy in any of those areas, they're going to affect everything else. So just thinking about yourself matters because you are one person in a part of a broader community. So what does that look like for you to consider your own personal health? Because if the health of our community matters, then that means the health of me and you, it matters, right? We can only give what we've already received. Just think about that for a minute, right? If I want to reach out and help my community and make a difference, am I myself already receiving that kind of help? Am I already opening up to looking at myself? We want to reduce the stigma. That's part of it, right? If we want to make sure we're promoting mental health in a community, then we need to reduce the stigma. But the stigma starts with me. Am I embarrassed about my stuff? Do I worry that if I open up and talk about my unhealthy thoughts or feelings or behaviors that somebody might judge me? That somebody might think maybe I'm not worthy of leadership. Maybe I'm not worthy of being a part of this community that's trying to build itself up, right? So if we're going to break down the stigma around mental health in any community, we have to start with ourselves. I have to look at me and say, am I willing to own the fact that I have stuff? What does that look like for you? I'll use it. This is kind of a gross analogy, all right? But let's just say you get in a car wreck or something, you have an accident, and you have this big, ugly, open, gaping wound right here on your shoulder. You got to go with me here for a second, okay? It's oozing, it's red, it's infected, it's gross, it hurts. Maybe when you touch it, it's hot, right? And you look out at your community, and you spot somebody and you say, oh my goodness, I know that wound. I've got one just like it, right? That's called empathy, by the way, and empathy matters. It matters that you look out and you care that other people are hurting the way that you hurt, right? But let's just say I see that person, right, and I see that big, ugly wound on them, and I'm moved with compassion, right? I want to reach out, I want to do something about it, so I go to hug them. And as I reach out, they bump up against my wound, and I say, ow! We call that triggered. You ever heard of the word triggered? I'm triggered, right? Somebody else's stuff is bumping up against my own stuff. Well, I'm of no use to somebody to help, right, to help things get better if I'm still walking around with my own wounds, not attended to. So what do I got to do to that wound to help it get better? I got to drain that thing. I got to take care of it. I got to attend to it. I got to put some kind of, my mama would have put Neosporin on it, right? Neosporin and a Band-Aid. You got to give it some time. You got to give it time to heal. You got to get that wound, your own stuff, has got to get to scar stage. Y'all know what I mean by a scar stage? What I mean is you can still see the evidence of it there, but it's no longer tender to touch. Did you know that scar tissue is stronger than regular flesh? Because see, now I'm walking around with a scar, right? Because I've been doing my own work. What do I mean by doing my own work? I'm healing. Thank you. I've been to therapy. I have a counselor. I'm not ashamed of the fact that I've got stuff. Because we all do. We all do. My mama says if you've got a belly button, you've been traumatized. There's some truth in that. That's not to diminish, right, really big trauma. Some of you in this room, you may have had some really serious trauma that has impacted you. So my question is, where do we start? We got to start with ourselves, right? We got to be willing to break the stigma around ourselves. I got to step up and push back from shame for me. And I got to get myself to some good counseling. I got to work through my stuff. I got to get my wound to scar stage. So now I'm walking around and I've got this scar where that wound used to be. And I look out and I see somebody else with a wound. And I say, oh, I know how that feels. Right back to that empathy again, right? Empathy matters. It's important that I can look out around my community and see who's hurting, why they're hurting, what can I do to help? But now my empathy can be activated. See, now I can reach out and I can try to help and I can bring somebody in, I give them that hug. It doesn't hurt anymore. Right? I've processed through my own stuff, I've dealt with my own wounds, and now I'm ready to be an active participant in pushing back the stigma in my own community. It's got to start with me. That's my challenge to you tonight, is let it start with you. If you've got stuff, there's no shame in that. If you've got a wound, go get some help. Get that thing some Neosporin and a bandage and give it some time. And then stand up proudly and say, you know what? I'm going to stand up there too and I'm going to say, I've got stuff. We're breaking down this stigma because everybody's got stuff. And the more you do that, the more that dominoes into the people around you. And everybody stands up and says, you know what, me too. I think I'll go get some healing. I'm going to get better. And one at a time, we tap one another. And before you know it, everyone's walking around unashamed because we've all got stuff. We're all working on it. We're all getting our own healing. And we live in a community where that's not stigmatized. And in a community where there's no stigma around having stuff, where getting good therapy is just normalized, right? It's just a part of the good community systems. It's right in there with transportation, hospitals, economic development, mental health counseling, boom. It's just all in there. All right, so we're looking around at all these tables. These are people who are setting up, becoming a part of a community system because they're looking out and they're looking for those wounds and they're saying, how can we help? What can I do? We got to know who one another is, but we have to hold each other accountable. You cannot lead people where you're not willing to go. So my challenge to you tonight is to deal with your own stuff. Break your own stigma. And then reach out to your family next, your neighborhood, your church communities, your school context, your work environment. Everybody that is around you is going to watch you get freer, and they're going to say, hey, what's going on with you? And you say, well, I got stuff, but I'm working on it, and there's no shame. And I'm going to be a part of making a difference in my community because mental health matters. Communities are made up of people, and people matter. Those people matter, and they need us. They need us to come together on nights like this under really good leadership and say, hey, let's come together, right? Because while it starts at the individual level, from there, we start expanding back into those relationships. And in relationships, there is a lot of power to work toward a better community. Because we can start now with us, right? So I've moved beyond me into us, and we come together and we say, hey, there's no shame. Stigma? What stigma? In our community, mental health matters, and it's a part of what we do. Oh, and don't you know, everybody's got stuff. This is how we start to break it down. And that's my challenge to you tonight. It's so nice to meet all of you. I'm glad you're here. Thank you for what you're doing already, because I know so many of you are doing so much already to make a difference. So thank you for all of that.
Brooke has a double commitment, and she's going to present on conduct disorders. So if you will allow me to interrupt you, I'd like to have Brooke Daniels talk about conduct disorders. Thank you.
First of all, I would just like to thank everyone for showing up and showing your appreciation for this program. About conduct disorder. My sister, for one, has conduct disorder, and it's resulted from ADHD and bipolar depression. There was a case study by Raj, a 14-year-old male teenager who was affected by conduct disorder. Conduct disorder patients have a hard time acting correctly in public, especially in society. They do not know how to conduct themselves in the right manner in the community. In Raj's case, his mother, a hypothyroidism, the hormonal treatment taken for conceiving and medications taken during pregnancy was taken as root cause and infections, as well as vaccinations to be the trigger of this disorder. Based on the symptoms described by the parents and our observations, a single dose of the simulum was given, followed by regular medications and was regular follow-up. The casual modeling framework, involving 3 levels of description: biological, cognitive, and behavioral, has previously been used to compare casual accounts for dyslexia and autism. The method and article, we present this framework and explore its application to 4 casual theories of conduct disorder. Conclusions. The application of the framework helps to see the relationships among the various theories of aspects of conduct disorder and demonstrates the need for more explicitness in the casual theories. Which gender and age is most affected by conduct disorder? A conduct disorder is more common in boys than girls. Why? I don't know. Just is. It is also more likely to develop in children or teens who come from homes that are disadvantaged, dysfunctional, and disorganized. Children with these mental health problems are also more likely to have conduct disorder, mood or anxiety disorders, post-traumatic stress disorder, substance use disorder, attention deficit hyperactivity disorder, or ADHD, and learning problems. Children or teens who are considered to have a difficult temperament are more likely to develop behavior problems. What causes conduct disorder in a child? Experts believe that many factors play a role in conduct disorder. These are brain damage, a traumatic event, genes, child abuse, past school failure, and social problems. Some children with the conduct disorder seem to have a problem in the frontal lobe of the brain, which I showed on the first part, like the first page of the slides. This interferes with a child's ability to play, stay away from harm, and learn from negative experiences. Conduct disorder lies on a spectrum of disruptive behavioral disorders, which also include ODD. In some cases, ODD is a precursor to CD. CD is characterized by a pattern of behaviors that demonstrate aggression and violation of the rights of others and evolves over time. Conduct disorder often occurs comorbidly with other psychiatric conditions, including depression, attention deficit hyperactivity disorder, ADHD, and learning disorders. Comparison, U.S. versus Germany. The prevalence of undiagnosed or diagnosed CD differentiate 31-fold between countries, 1.1 for the USA and 3.1% Germany. Variation in rates of CD diagnosis and implementation of evidence-based interventions between nations. Between 4.0% for Germany and 12.2% USA of youths with CD diagnosis were prescribed antipsychotic medication, and 1.2% Norway to 12.5% Germany underwent psychiatric hospitalization. Sorry guys, I can't pronounce anything correctly. Therapeutic treatment. Treatment for conduct disorder may include multi-systematic therapy, intensive, often home or community-based, interventions to promote positive behavior change in the youth's environment. Treatment relies heavily on family and school environment, family therapy, and medication. Symptoms and signs of conduct disorder. There are 4 basic types of behavior that characterize conduct disorder. Physical aggression, such as cruelty towards animals, assault, or rape. Violating others' rights, such as theft or vandalism. Lying or manipulation. Delinquent behaviors, such as truancy or running away from home. Behaviors. Bullying or threatening behavior, physical aggression, cruelty toward people or animals, fire setting, breaking curfew, truancy from home or school, trespassing, lying, cheating, stealing, and vandalism. Emotionally or physically abusive behavior, such as a wielding of a weapon or forcing sex. Many people with conduct disorder will have trouble feeling or expressing empathy or remorse, showing emotion towards others, performing well in the school or community, and blaming others for poor performance. Two types of medication known for conduct disorder is dextrogene and Ritalin. Do we have any questions?
Just a few minutes for questions, if you have any comments.
If you don't, it's okay.
Okay, let's get prepared, please. If it's okay with everybody, we're running a little ahead of time, but I think it's a good thing, so we'll just resume with student presentations. And the next individual that we have is going to present is Mr. Jay Stewart. Mr. Stewart is a business major in nursing, is that correct?
Business right now,
Business.
nursing.
Okay, business and eventually nursing. Okay. If you come up, please, sir.
All right, thank you, Dr. Spires.
You're welcome.
It's an honor to be here. I didn't know what this was going to look like because I've never been to one before. But let me go ahead. I'm really excited. Understanding mental health is so important in life, and we share in this life together. So anyway, my introduction is I'm James or Jay Stewart. I'm 62 years old. I presently work for DaVita Kidney Care. That's a dialysis clinic. I'm in Chipley, but I also work over here at Mariana. I'm a certified clinical hemodialysis technician. I'm a preceptor, and I'm an access manager. I make sure all the accesses are healthy. Anyway, so that's now. If you want the long version, I've got another hour later that I can tell you from anyway. So I am pursuing an AA degree in business, and my goal is to also get an associate's degree in nursing. And my reason for doing this is because in order to be able to move forward with my employment, I want to be a facility administrator. I'd like to be able to run a clinic, and I require an AA degree. So that's what connected us. But why I'm here is about what we're doing right now and what this college represents with education. Tonight I'm going to be talking about a phobia. It's called agoraphobia. And when I selected this, it was looking at panic disorders, and I thought that it's just a subset actually of a panic disorder. And I looked up the word agora, because it's a phobia, it's a fear, right? But what agora means is it's a gathering place, like the marketplace in ancient Greece. So it's an older word, and so it's the fear of open spaces. And as it's defined, it's the fear of open spaces of where the public meets, and that could be malls, open places like this even, transportation, everywhere you can be out in the open. And it's specific to that. Even though it is a panic disorder, actually it's the fear of the onset of a panic attack. So somebody who has agoraphobia is someone that is afraid and avoids places because there could be an impending panic attack. They feel unsafe. They feel like they couldn't get help if they needed it. So it's a very unique condition. And I titled this agoraphobia, A Strange Case, based on the case study. And we're going to move on to that. The case study is about so that's not where it needs to be. Don't read my notes. So all of it's not there. Okay, thank you. Oh, you were moving it. Okay. Thank you, Ms. Morales. She has been so supportive of me, and I appreciate her as a new student. She's offered just to make sure that I'm doing well as a student. So it's a strange case of agoraphobia, a case study of where there was a lady that is at 91 years old is when they began the assessment of her condition. And it was done in July of 2008. She was also living with her husband of 60 years. And what she was experiencing was an intense fear of dying or losing consciousness or not being found in time, fear of being buried alive. So I don't know if you could imagine if you've ever had any fears or phobias and feel threatened, that this is very extreme. And so I just was very interested in this case. And through her assessment and the interviewing, there was a couple of things that were noted. That in 1971, her brother had died in the hospital, and they took her to the hospital, and she wouldn't go in the room. She was just afraid of that environment. And then after that, earlier than that, in the 1950s, her niece reported that she was not able to tolerate being home alone and experienced panic-like symptoms. And it was bad enough that she did not want her husband to work, but he worked, and she would go be at different places at that time. And this was decades earlier, that leading to where she ended up being where they intervened. 17 years before they started the treatment, she was isolated to her bed, to the four corners of her bed. Wouldn't get out of her bed, couldn't go through the room, couldn't leave the room, couldn't go into another room, just completely consumed by fear. Where she was, let me see, make sure I stay on my notes here. Okay, and she was then provided with services such as a bedpan and sponge bath. She was healthy. She did have a colon cancer and had surgery for that. But otherwise, she was physically healthy and able but no, she wasn't. This is debilitating. A girl, mental conditions like this, they're debilitating, just as if it was a physical injury. So I'm going to move on to the treatment for Mrs. E.L. is what we called her. They treated her with Zoloft, which was sertraline, which is a little antidepressant. But they went from 25 milligrams at the beginning and built up to where they were giving her 150 milligrams to be able to help her. And it's, medication is a really good tool for helping cope and helping with other treatments, because it's not going to cure, but it is very important to be able to use all the resources available. She was also treated with cognitive therapy, with behavioral and exposure therapy, if you could imagine, with her fear, using one of the tools like exposure therapy. That would be, if someone just took her outside, that would be horrible. But it took months to do this, to get her from her bed to getting off of her bed to the door, baby steps, and moving her from to the living room. And then this is an apartment they lived in. And then they got to where she could go from another room, and then they go to another room and to another room where she began to expand her environment. And then toward the end, she was able to get to the door, and she was even able to step outside. And then can't recall the length of the treatment in years, that she was able to walk down the stairs with assistance. She couldn't do it by herself. She had to have somebody, that safety net. And then she, at the end of the results, and they considered this a really great success for her to expand her environment to the point where she can function within her environment within her apartment. And the last day that they were there, they said that with assistance, she came down the stairs and was able to see them off. So they considered that a really good success to be able to move her to that point. Let me go ahead and I think it's this one. Nope. Okay. So Carl Frederick Otto Westphal, he was the one that coined the phrase agoraphobia. In 1871, agoraphobia was the first described by him, and he was a German physician. He coined the phrase and termed it after observing 3 of his patients who exhibited severe anxiety and dread upon traveling to certain public areas of Berlin in the city where he worked. So that's the guy who founded it. And let me go ahead and move to the next slide. So I wanted to do a comparison with cultures. I found a lot of records for different cultures, like American Asians and different cultures within. But I wanted to look outside of America, and that's too small for me to read. I put that I was just going to read that for you. So in the American culture, most Americans harbor positive views about mental health disorders and treatments. And this has really progressed over the decades from being more of a not being aware and understanding what mental health conditions are. So there was always stigmas to that in our society. Her word. A total of 87% of American adults agreed that having a mental health disorder is nothing to be ashamed of. And that's a growing number today. 86% of Americans believe that people with mental health disorders can get better. And I'm one of those 86%. Anyway. So, but in Asian culture, and I picked the Asian culture because I really appreciate the dynamics of honor, respect, and caring for one another and serving one another. So I chose them, and a great value is placed on the family unit over the individual, and that's not true just for family. That's true for their neighborhoods, their work environments, their they're part of a whole with a whole purpose in mind. Social stigma was shame. Saving face often prevent Asians from seeking behavioral health care. And then this one, Asian patients are likely to express psychological distress as physical complaints. So I think, just knowledge and awareness of what exactly is, and not being aware, we have a tendency to follow, the cultures that we live in and the belief systems that we have. And that goes from country to country and groups to groups as well. Okay, did I pass one? Nope. Okay. Therapeutic treatment. As I mentioned, the serotonin reuptake inhibitor, which was the Zoloft. Cognitive behavioral therapy, which includes, counseling, which is you can have one-on-one or group, where you can have group counseling, where you can work through what your, the issues. Developing self-help techniques. There's a lot of techniques on being able to be grounded, being in the room, being present. There's also journaling, the things that through counseling, you'll learn tools that allow you to be able to just to recenter every day. And the more you just move forward every day, really makes a difference. Let me go ahead to the next one. Okay, I put my thoughts, but these are the questions that were put on there, and I answered them for myself, but these are up there for you as well. Was there anything new learned about the disorder you did not know before? I did not have a clue that agoraphobia existed. But I can understand after looking through it and researching it that there is a distinction in this type of fear. And let me go ahead and go back to that case study. It didn't just happen overnight. There were signs of her life where different phobias and fears of being safe and secure grew and developed to the point where her wall eventually closed her in to the point where she was in her bed. The next question was, what do you think about the comparison of how the disorders were viewed in other countries? Which therapeutic treatment do you think works best? And how do you feel about the disorder now that that I've researched it? So would anybody like to answer this for themselves? This is like, you have any questions like maybe I can answer for you? Well, I'm going to continue. I'm going to answer my own questions, okay? I learned that how debilitating a mental health disorder like agoraphobia can be. And like Mrs. Ford, you remember the keynote speaker earlier talked about mental health and the value of having the triangle. And I cannot remember those points. I should have wrote it down. But having therapies available, having medications available, but it's a real thing. Okay, what did you think about the comparison? Again, I mentioned that different cultures and different mindsets are just different. They're not good and bad. They're not right and wrong. They're different. We have a tendency, our reality is based on what we believe. And for somebody else, their reality might be something different because of what they believe. That's where empathy comes in. Accepting of others' beliefs and honoring and celebrating that. Then I like the medication, yeah, absolutely, but I like the cognitive therapy where you have counseling, where you have somebody that you can trust, that you can go to, that you can share what your experience is in a safe environment. So I like that. And I feel it's important that we, not just for this disorder, but all disorders, to be able to be aware and to be able to be empathetic to others and just be there for each other and help anyway. I think I did skip the stat page. Let me go back to this. The statics of agoraphobia. Females are 2 times more likely to suffer from agoraphobia than males. Approximately 1.8 million individuals have agoraphobia in a given year. The average age of onset of agoraphobia is between 25 and 30. That's a long stretch from 91 years old. So the onset of what could begin to develop into more severe issues begin at earlier ages. Adults older than 65 have the highest prevalence of developing agoraphobia. So anyway, I thought that was very insightful. Anyway, so that's going to be the conclusion here. And I appreciate your time. Thank you.
Okay. Okay, the next presenter we have Mr. Dylan Lawley. Dylan is a psychology major, and he's going to share some thoughts with us today. Okay.
I just want to start off and ask how everyone is doing this evening. I am doing good. A little bit nervous, but good. But really, when we really ask ourselves and really ask each other, how are we doing? The 3 words that come to mind and we tell others are good, all right, or fine. We often say these 3 words when someone asks us how we are feeling or how we are dealing with our emotions. But if we were all honest with each other, what would we truly say? Many people are not honest about their true feelings and emotions due to the fear of being criticized or judged by others. And that is what causes the mental health stigma we see in the world today. What is mental health stigma, you might ask? It is marking and discrediting people due to their differences, which can instill feelings of shame or worthlessness. Those with mental health conditions may be labeled, stereotyped, or discriminated against as a result. Mental health illnesses, I went too fast. Mental health illnesses are on the rise and will continue to rise if we do not address this stigma that we have in the world. It's not just in the U.S., it's around the globe. Some mental illnesses that are common are depression and anxiety disorders. Most of us, we deal with these disorders, but you walk up to somebody, you would never know that they deal with that. Oh, come on. All right. But the DSM-5 categorizes major depressive disorder as F32.0 and generalized anxiety disorder as F41.1. Major depressive disorder occurs when you have long depressive episodes, weeks and weeks and weeks without any improvement. You get deep down. And generalized anxiety disorders, we have panic attacks, for example, or something. As you see, mood swings, withdrawal, isolation, and you also have lack of motivation. People with mental illnesses are often judged because of their emotions and diagnosis. But do not let that diagnosis define you. Prove to yourself and others that the diagnosis will not define your life. And when I saw that, share your story and inspire others, that's what I want to do with my life, is I want to help people and inspire them to stand up and get rid of the stigma, because you should not be ashamed of what you're diagnosed with. Do not let it define you. But let's use schizophrenia or borderline personality disorder for an example. People will see or tell these individuals that they are crazy or mentally insane and need to be placed in a mental health facility. But if you have been placed in a mental health facility or a hospital, do not be ashamed, because you received the help you needed, and that's all that matters. You overcame it. That's what matters. You brought yourself out of that hole. You were brave and courageous during a time of crisis. But I want to encourage you to share with others how you overcame and how you are dealing with your mental disorders or how you're dealing with your emotions. Because you could be that person that helps someone else who is struggling with the same disorder as you. You never know, it could be in Walmart. You never know who you could walk up and you could impact their life. Due to mental health stigma in the world, less people are asking for help, and as a result, the suicide rate is higher than ever and continues to rise. And that is the suicide awareness ribbon. According to SAID.org about suicide, they estimate that there is a person that commits suicide every 14 seconds. So just imagine you're sitting here and, we see, we look at our watch and it hits 14. We don't think nothing about it, but if you really sit there and think, oh my Lord, somebody just took their life. And that should touch your heart and say, we need to put an end to that or help prevent that from happening. Suicide is a very important subject that needs to be addressed. Most often, people do not want to talk about it because it is a very serious issue and concern. And there are several reasons why someone would commit suicide. Some such as bullying, cyberbullying, which we see in a lot of schools, which is absolutely terrible. I think social media with cyberbullying has taken it out of control. Stressful life-changing events such as divorce in your home or something, or moving to a new place, or passing away of someone that has most importance to you. And there's much more that could be said, but it's not just in schools, it's in homes, it's in colleges, it's in the world. You being hateful to somebody or saying to somebody, nobody likes you or nobody cares about you, that's bullying. And that nobody should say that to anybody, because everybody is cared for. But there are hope and reasons to stay alive, as you will read up there. The feelings before and after. But I want to let all of you know that there is hope and reasons for staying alive. I know the battle is tough. I know times are hard. But trust me, I understand, because I have gone through the feelings of emptiness, hopelessness, worthlessness, and pain. You are loved and cared for, and it will get better. There is hope and purpose for you. And everybody always wants to feel hope, joy, peace, and purpose in their life. That's what we all eager. I think we could all agree with that. So if you have these feelings, do not hesitate. Reach out for help. These resources are out there for each and every one of you, and they're here tonight. And that is the Suicide and Crisis Lifeline, 24/7, 365. Do not hesitate. If you have a thought or any kind of suicide thought or attempt or anything, just please call this number or get somebody that you know and talk to them. That's the main thing, is talk to them. And that's what this mental health stigma is doing. It makes us close up our emotions. And that's why it needs to be addressed. But if we think about what the word hope and what it stands for, you will feel healing, peace, encouragement, and you will be an overcomer. The letter H stands for healing. Healing is something we all desire when we're broken. We want to feel like during a breakup, we want to feel that healing that we need. The letter O stands for an overcomer. It could be anything, not just with suicide. It could be overcoming anxiety about a test. It could be anything, or having anxiety about when you first drive, you overcome things in life like, oh my Lord, I gotta, just standing up here today, I'm overcoming that. I'm describing the word hope just standing here today. And the letter P stands for peace. Peace is something we all want. This world is a mess. We can all see that. And we all just want peace in our lives, in our homes, in our families, in our schools. We just want peace. That's what we desire. And when you get down and you get depressed, you ask for peace. I'm sure we could all agree with that. You say, I want peace, I want joy, I want healing from this brokenness. And lastly, the letter E stands for encouragement, and that encouragement comes from others, or it could come from, like, most stuff. They have motivational stuff on TikTok, YouTube, whatever. But encouragement comes from others. That's the most important, because that is your support system. That is who is there for you. And if you can find that, it could only be one person that supports you. And that could be enough to save your life. So let's help end this stigma and bring hope to individuals struggling with emotional health issues. But I also want to thank, and I have appreciated this opportunity to share this with all of y'all. I hope I have impacted at least someone or many this evening. Special thanks to Dr. Spires, Ms. Morales, and Chipola College for putting this event together. I want to end this speech with one question. Are you okay? Just think about that for a second. Are you okay? Just examine yourself and say, am I really okay? And that's when those words come to mind. We'll tell others we're fine, or I'm doing all right today. But are we being honest about what we said? That's where that stigma comes in. If that stigma ends, we can share and express our emotions and get the help that we need. But if you are not okay, please reach for help. Like I said, the 988 number, there's plenty of people to call, life management, anybody that you know can get you the help, law enforcement, whoever you feel comfortable talking to, that can be the person that can save your life. And when you reach for help, you become part of that Hope 14. And myself am living proof of Hope 14. Because like I said before, I have been in those feelings. And if it wasn't for hope and what it stands for, I would not be standing here talking to you today. And that's why I wanted to express this, and that's why when Ms. Morales first asked me to speak to all of y'all at this symposium, I was like, I was questioning it, but now I'm happy because I feel like I'm inspiring others, and I could save that next 14-second person from doing that. They think it doesn't happen around here, but it does. It happens everywhere, all around the world. And I just want to say thank you for your time, and I am living proof of Hope 14. Thank you so much.
Okay, our next presenter is on this topic of narcissism, Ms. Abby DeVos. Did I get it right? Okay, come on up, please. And Abby is a nursing major, right?
Yes.
Okay.
I'm just a little nervous. Narcissism originates from Greek mythology, the story of Narcissus. Narcissus fell in love with his reflection so much that he was cursed for being conceited. Narcissists have a fragile self-esteem. They feel special and unique, so they feel that others should welcome and admire them. And I have the symptoms that spell out special me. My case study is on a 22-year-old named Elliot Roger. In 2014, he killed 7 people, including himself. As a child, he was coddled by his parents. Parents who were indulgent and minimized their child's unhappiness deprived them of the experiences of controlling their desires and emotions. Without the capacity to control these emotions, they develop into egotistical monsters. After his crime, he became a hero in the community that he was a part of. He was named Supreme Gentleman. Ever since his rampage, incels have become more violent. Over the past 10 years, several incidents of mass violence have been committed by men who consider themselves incels or believe in male supremacy. Males are 75% more likely to have narcissism than females. It normally begins in teens and early adults. Sorry, the video doesn't have any sound. People that have narcissism are hypersensitive to critique and rejection. They become angry, spiteful, and violent to the person they believe is mistreating them. Psychotherapy is one of the treatments for this condition. There is no medication, but they use medications for depression and anxiety to treat narcissism. People with this condition don't usually seek help because they believe that nothing is wrong with them. And that is it.
Any questions on narcissism or comments? Okay, thank you. Okay. And the next individual is going to talk about Munchausen by proxy, and that's Miss Litany Francisca. Okay. And come on up, please, ma'am. Nutrition and dietetics major, is that right?
Sorry?
Nutrition and dietetics major, is that your major?
Yes, that's
Okay.
pre-med.
Okay, sure. Okay, pre-med.
Okay. Hello, my presentation is about Munchausen by proxy, and a famous case study would be about Gypsy Rose's mother, Dee Dee or Claudie Blanchard, and she went through many procedures that didn't have to be done. She also made many illness for her and made her believe that she was really sick, which she really wasn't. She also lied about many other things in her medical records. Another case would be a 18-month-old that was put through recurrent hypoglycemic attacks as a case of persistent hyperinsulinemia, hypoglycemic of infancy, as doctors noticed that it only happened when the mother was around, so they took her in observation. and during the observation, the child was perfectly fine. Some symptoms cannot be seen clearly until they think about it, and most healthcare providers will not take it in account. But some obvious symptoms for this illness are adding substance to test items, making up lab results, or alternating them, symptoms that are not there when at the hospital, but they do happen when they're at home. Patient sees hospitals or healthcare providers a lot, and samples that don't even match to the patient. The caretaker speaks for the patient as if they were the sick one. The psychological theorist for this mental illness would be Dr. Roy Meadow in 1977. He used the word Munchausen syndrome by proxy to describe children whose mothers produce histories of illness to their child and who support such history by fabricating physical signs and symptoms, or even by alternating laboratory tests. Munchausen comes from a Russian army guy that came back from a war and would exaggerate everything that it made it almost unbelievable. The statistics. The Cleveland Clinic reported that about 1% of people have Munchausen syndrome, and 2 in 100,000 children are thought to be victims of Munchausen by proxy. However, estimates suggest that about 1,000 of the 2.5 million cases of child abuse reported annually are by Munchausen by proxy. It is mostly seen in mothers, and the victims are usually around the age of 6 or under. In the UK, there was a two-year study, and during that period, a total of 28 cases were identified. 55 suffered of Munchausen syndrome by proxy alone, 15 poisoning and 15 suffocation. 43 suffered more than one type of abuse. The majority of the children were aged under 5, and the median age being 20 months old. On 85% of the occasion, the perpetrator was the child's mother, and 42% of families were more than one child. A sibling had previously suffered some form of abuse. In the U.S., about 6% of all reports of suspected child abuse to Child Protective Services is related to abuse or Munchausen by proxy. The condition is vastly underdiagnosed, the experts say. The therapeutic treatment. There are none that are useful that make the illness go away. Some have tried drugs or therapy, but none have shown to prove the mental illness go away. This is a very serious illness that must be addressed, as it is creating child abuse and so much trauma for the child to live in. It is not only child, but sometimes it happens in children that make their elderly parents sick or make up fake symptoms for them to get what they want. It is not talked much about because until now I have not heard of this mental illness, and it has to be addressed because it creates child abuse, which should not be happening to our children.
Okay. Wonderful job, students. Good job. Okay. Now we're down to the part where we have the agencies. We want to recognize you and give you an opportunity to say a few words about your agency and what service you provide. And first one I have on my list here is Ms. Karen Edwards, of the Jackson County Health Department. Come up, please.
I'd just like to say we are very pleased to be here. I am here on behalf of my health officer, our administrator, Mrs. Sandy Martin, who really believes in the Jackson County community and is always open to us serving and working with all populations. I'm here with my coworker, Emily Bass. Would you wave your hand, please? I am the tobacco prevention specialist at your Jackson County Health Department. And Emily is our health equity specialist there as well. We always try to attend this event because the population that all of you talk of, there is a great correlation to those who come and receive services at our establishment. And we want everyone to know they are welcome at the Jackson County Health Department. Tonight, we specifically talked to you all at the table a lot about the tobacco prevention program, which, as I said, I'm the tobacco prevention specialist. But it is because there is a great correlation between those that have mental health issues and tobacco use. There's often a lot of targeting, and I've always said tobacco is the one product, if you use it exactly as it should be used, is guaranteed to kill you or reduce your life. So we just want you all to know that any services you have, any connections you need, we have a social service department. We will partner with individuals, and we are here for you and to provide services. I appreciate Dr. Spires and Mrs. Morales. They always say we help them, but they help us because our job is to serve you. Thank you for having us here tonight.
Okay, the next agency is Behavior and Life Connection, LLC. We have Mrs. D. Johnson. Look here, your card, please. Come up. One of you, please. Did they leave early or something? Oh, okay, there you are, okay.
Hello, everyone. I'm with Behavioral and Life Connections, and we work in the community working with children with autism. We work one-on-one in their home, in their school, and in the community with them. And what we do, we go in and evaluate to see the function of their behavior. So every living organism has one of the behaviors that we do is for one of the functions: attention, escape, access to tangible, and sensory. And so what we do, we go in and evaluate what that function may be of their maladaptive behavior, and we replace it with an adaptive behavior. And so for attention, we engage in those behaviors in order to receive attention from other people in their environment. So parents, teachers, peers, siblings, these behaviors function as a reinforcer because it has resulted in receiving attention or social interaction in the past. Escape behaviors, we engage in those behaviors in order to escape an aversive situation or person. These behaviors are reinforced because they allow us to get away from something that we do not want to do. Access to tangible, we engage in these behaviors in order to gain access to a tangible item or a desired item or activity at that time. Sensory, we engage in these behaviors in order to gain access to sensory stimulation. Sensory behaviors can occur at the time of the presence or absence of another person. So that's how you can distinguish if a behavior that we're doing is sensory. And then, so like I said, we just go in and evaluate and try to get an appropriate replacement behavior. So I know a lot of you guys stopped at my booth, and we have like an example, it's called What's That Function? And a lot of you guys chose, like, if the child goes into Walmart and sees a toy, either they tantrumed or cried or did some kind of maladaptive behavior, and then the consequence you guys said that the child got the toy or the parent picked the child up. And so what we'll do is go into that situation and teach the parent to no longer give them that toy, no longer give them that attention, pick them up or anything. We teach them to have the child wait, teach them to act tax when they can have the toy, earn X amount of trips to the store, and then they actually get the toy. So we always want to replace a maladaptive behavior with an adaptive behavior. And so that's the main focus of our organization, to help not only the child have a quality of life, but the entire family. And that's it.
Mrs. Brittany Barnes, please. Come forward.
Good evening, everyone. My name is Brittany Barnes. I'm a local mental health therapist here in Jackson County. But tonight I'm here as a representative of American Foundation Suicide Prevention Organization to provide resources about suicide prevention awareness. This passion of mine came specific from my personal experiences of being a survivor of suicide, where I've lost 2 people in my life within the last couple of years that they died by suicide. We provide awareness about prevention to prevent suicide for veterans, for a variety of populations, adolescents, for everyone. It's a everyone type of issue. And I just thank you for having me here tonight, and I appreciate Dr. Spires and Ms. Morales. Thank you.
Okay. Moms of Lost Children, Ms. Priscilla White. Moms of Lost Children, Ms. Priscilla White. No? Okay. We'll move on then. To Emerald Coast Behavioral Blue Springs Outpatient Center. Anyone here for that one? Okay. One Step at a Time, Incorporated, Tricia Masseline.
Hello, everyone. My name is Trivia Masseline. I'm the founder of One Step at a Time. Basically, what I deal with families that experience the mental health. Like a lot of them that experience mental health, they either do one of the 2 things. They either become homeless or they become incarcerated at a jail or a prison. Basically, what I do, I provide resources to these families so they can retain jobs and housing. And other things as well, like food drives, mental health awareness, if they need counseling of some sort, basically whatever they need may be, to keep them from going back to jail or prison and keep them from being homeless. So I'm glad to be here tonight, and thank you, Dr. Spires, and thank you, Ms. What her name is, Morales. Thank you, ma'am. And if y'all want to know anything else, just come by. All righty.
Okay. Gulf Coast Sexual Assault, Ms. Marsha Crew. Come on up, please.
Hi, y'all. I'm Marsha Kroom. I'm with the Gulf Coast Sexual Assault Program, which is a program under the Gulf Coast Children's Advocacy Center, and we do 2 things that might be important for you. We are the rape crisis line, so if someone is assaulted, sexually assaulted, and they go to the hospital, they call law enforcement, they call us. And we provide the forensic exam as well as advocacy if they decide to press charges and it goes to court, and we'll follow them and support them through the case, the length of the case. We also provide free trauma therapy for adults who were abused as children or for adults who were abused as adults and need to work through some of the trauma like the first speaker was talking about with the scar on your shoulder. And it costs 0 money to you. I have swag in the back that has our hotline number. All you have to do is call the hotline and say, I'm an adult that was abused as a child, and they will hook you up with some free trauma therapy. They usually do EMDR or other tools to help you work through the triggers that you guys might have. Thank you. We can do the exam in our office or at the hospital. We have MOUs with both places. Yep.
All right, thank you.
Yep.
Okay. Florida Center for Early Childhood, Ms. Jennifer Warden. Okay, there you are. Okay.
Hello. So my name is Jen. I'm with the Florida Center for Early Childhood. We are based in Sarasota. However, we serve the entire state of Florida. Really excited because I work with our FASD program, which is fetal alcohol spectrum disorders. So that's going to be anybody impacted by prenatal alcohol exposure. If you are a Florida resident and under the age of 22, those individuals would qualify for our free assessments. On top of that, we are able to do specialized mental health services for either the individual or their caregiver. That way they are working intentionally with tools and interventions that are going to help be successful. In addition to that, we have caregiver-specific support. So whether that be helping to advocate at the policy level or if we're advocating at school, whatever it is, we're wanting to set those individuals up for success so that they can reach whatever their version of success is going to look like. So our Pensacola clinic is opening in April, and so this is really exciting for the Panhandle to kind of have our own spot for FASD.
Okay. Does the family have someone who's diagnosed with fetal alcohol syndrome, or is there help for someone who is drinking heavily and pregnant?
So Dr. Spires asked if we are able to serve individuals who are drinking. Right now, our program, we're child-focused, but we would absolutely be wanting to help connect others to any recovery or the services available. So.
Okay, thank you.
Yes, sir. Oh, and in case I didn't say it, we're free. We don't charge insurance. I don't want to know about your insurance. I don't want to take your money.
Okay, great. Okay, Bay County Vet Center, Mr. Matthew Standish.
Thank you, Dr. Spires, Ms. Linda, for having me out again this year. I'm really privileged to be here. Love talking to everybody. How's everybody doing? Good. I like to hear that. Everybody got a smile on your face? Cool. That's the way I like it. I love making people smile. So my name is Matt Standish. I'm with the Bay County Vet Center down in Panama City, Florida. And for all of you who already stopped by my table, sorry you got to hear this speech again, okay? But what we do is something very, very beautiful. I work for a very special office of the VA. We are federal VA, so we're fully funded. There's no cost for our service. But we're intentionally cut off and separate from everything else in the VA, okay? We don't belong to the health system, so we don't deal with hospitals, we don't deal with clinics. We don't do anything with benefits or claims, but we know the people that do. So if somebody needs that, we can point them in the right direction. But vet centers are a very special program that provides counseling services, okay, working on mental health. Our primary focus is post-traumatic stress, whether that came from combat service, sexual trauma, dealing with casualties, deploying to a natural disaster site like our National Guard troops might, even Coast Guard who've been out doing drug interdictions and pulling bodies out of the water, those kind of things. And what we do, it's really beautiful. Because of the way we're set up within the VA, first off, our veterans that come to us don't have to be in the VA system, not at all. They can have nothing to do with the VA, and they can still get seen at a vet center. That also means if they have other than honorable discharges, they can still come see us. But for about 10 years now, we've also been seeing National Guard troops, reservists, and even active duty members, and we are the only office in the VA that regularly sees family members. And that's any family member, even boyfriends, girlfriends, because if, everybody knows PTSD destroys families. It just tears them up. So we can see, like I said, parents, children, spouse, just about anybody. So what we do, and there's over 300 of these vet centers all across the United States. You know, it's a national program. Even our territories, Puerto Rico, Guam, U.S. Virgin Islands. What we do, and we're all basically the same, is we provide a safe place where that veteran or troop out there who won't talk to anybody, they can go to any vet center in the country and pretty much just walk in the front door. They'll get connected to a licensed professional counselor who may also be a veteran themselves. Then most importantly, though, is nobody will ever know, okay? Not even the VA. So it's extreme confidentiality. You know, it's like that one last safe place where that veteran or troop out there who won't talk to anyone will have nothing to worry about. No excuses. They can go to the vet center and have someone to talk to. Probably someone who's been there themselves. So we love what we do. It's a really beautiful service and we love it. We have one really huge problem. Nobody knows about it. See, this program is actually over 44 years old. It was started by Vietnam veterans back in the 70s. But from day number one, there has never been a commercial. There's never been an advertisement. It's all word of mouth. So me, I'm a retired Air Force First Sergeant. I have way more fun than I should be allowed, okay? Plus I love making people smile. And the VA pays me to run around 11 counties and do nothing but talk. I have a ball. I love what I do because I'm taking care of my brothers and sisters too. So the big favor I need from you, if you haven't gotten a brochure yet, stop by and grab one. If you know a veteran, active duty member, or their family member, and they are having problems with something, tell them about us. Share it with them, let them know that we're there. Our brochure has a locator on the back, so even if they're in another part of the state or in a different state entirely, you can find the nearest vet center to any location. And then the one good thing that COVID-19 did for our vet center programs, so if there's not a vet center close, we can do all our counseling virtually if we need to. Telephones, videos, whatever we need to do, we can set it up. But help us spread the word, let people know about us. The biggest thing we got going on right now is we hired a new counselor. She's actually from Mariana. That reminds me, we do have a group that meets here in Mariana every Thursday. So if there's a veteran and they don't want to come down to Panama City, we can hook them up here. But we've hired a new counselor. She lives here in Mariana. She's actually going to Dothan, Alabama once a week right now. And this is the start of a new process that as she gets busy, we're going to add more counselors. And as they get busy, eventually it'll result in a brand new vet center being built in Dothan, Alabama. So we're really excited about that. So spread the word for me. Let people know that we're there for them. Help us take care of our brothers and sister veterans. And just God bless you. Have a safe trip home and enjoy, all right? All right. Keep smiling.
SOAR, Ms. Christina Talbot. Christina Talbot. SOAR, no? Okay, vocational rehabilitation, Ms. Tiffany Sorey, Ms. Darlene Boykins, and Ms. Paula Wynn. Okay.
Good evening, everyone. Y'all can do better than that. Good evening, everyone. Thank you. I'm one of three that is representing the Florida Department of Education, Division of Vocational Rehabilitation. My name is Paula Wynn. I'm here with my supervisor, Ms. Darlene Borkin, and my co-worker, Ms. Tiffany Sorey. And what we do is just what our name says, vocational rehabilitation. We help rehabilitate people that may have a mental disability or a physical disability to the point so they can go back to their vocation that they may be already in or a vocation that they're intended to be in. So if we have someone that may be employed and they have a mental or physical disability, our whole goal is, with employment agency, we help people stay employed or become employed. And we also provide employability services as well to students that are 14 to 21 years of age. We do that as well. So everything we do is centered around employment. So we have students that may come to us that want employment skills to help them get on the path. So once they're completed with their high school or they're going to college and they want assistance from us to become employed, we can help them with that. And we also work with adults as well to help them maintain their jobs or obtain jobs. Okay, any questions? Thank you. Thank you.
Okay. Chemical addiction recovery effort, Ms. Jen Richardson.
So some of you guys already heard this, but Chemical Addiction Recovery Efforts, or CARE, offers residential and outpatient services for those who struggle with chemical addiction. We also offer free medicated assisted treatment, and that helps with withdrawal symptoms and cravings. And we have a women's residential facility in Alford and a men's residential facility in Panama City, as well as our detox in Panama City, but we cover the 6 counties in this area.
Okay, I omitted the fact that with Jen, there's Miss Rose Smith and Miss Kelsey Davis. Want to recognize them as well. Okay, and then the Hope Project, we have Mr. Kevin Holland, Miss Bunny Blackburn, and Mr. David Trotman.
Thank you. Appreciate you letting us be here today.
You're very well. Welcome.
I'm Kevin. I'm with the Hope Project. We rescue horses, then use them in equine-assisted psychotherapy for military, first responders, their families, any kind of trauma, sexual assault, to human trafficking, special needs children, and we're 100% free. We work on donations only. None of us take salaries, no matter if we work 80 hours a week, it don't matter. I work with the Vet Center quite a bit, with Matt. CAC, worked with them quite a bit. That's about it. Any questions? Anybody want a horse? I got one I'll give them. No? I tried. You're more than welcome.
Okay. I believe that concludes all of our presenters. I do want to afford everybody or anyone the opportunity to ask questions and make comments. I'm sorry, did I miss someone? Did I miss someone? Omit someone? No? You want to say something? Okay. All right. Don't want to leave anybody out. If so, just let me know. And once again, I want to thank everyone for being here, and it certainly would not be possible without your participation. And each time that we have these programs, I realize how we are so interconnected, because whether you're a private therapist or a public agency, we all can assist each other in providing services that are so desperately needed in our communities. So I appreciate everyone for what you do and that type thing. And I learn something new every time we have a symposium. So let's continue to work together for the betterment of society in general. And once again, thank you for being here. Okay. Oh, yes. There's some surveys you should have got when you came in, or if not, there's some at the back. Please fill those out so we can get an idea of what you want us to add to the program next time, okay? Thank you.